very pleased to have Bill Rouse. So Bill's work I know of even while I was doing my PhD. So a lot of people talk about this human-computer automation these days, how computers are going to be assistants to humans. Bill actually did that in the 70s already while he was at the University of Illinois. He's the Alexander Crombie Humphreys Chair within the School of Systems and Enterprise at Stevens Institute of Technology. And he also directs the Center for Complex Systems and Enterprises. He's also Professor Emeritus and former Chair of the School of Industrial and Systems Engineering at Georgia Institute of Technology. As many of you may or may not know, that Georgia Tech's Industrial Systems Engineering is probably #1 in the country. His research focuses on understanding and managing complex public-private systems, such as healthcare delivery, urban systems, and national security, with emphasis on mathematical and computational modeling of those systems for the purpose of policy design and analysis. I think he's written almost 14 books, most recent ones, and he has written hundreds of articles and book chapters. The book on modeling and visualization of complex systems and enterprises, and understanding and managing the complexity of healthcare, both MIT Press and Wiley. Economic systems analysis and assessment, people and organizations, explorations of human-centered design, essential challenges of strategic management, and the award-winning Don't Jump to Solutions of the set of some names of books. He has edited or co-edited numerous books, including Engineering the System Healthcare, The Economics of Human Systems Integration, Enterprise Transformation, Understanding and Enabling Fundamental Change, Organization Simulation, from Modeling and Simulation to Games and Entertainment, and the best-selling Handbook of Systems Engineering and Management. That was published in 1999 and then republished in 2009. He did that with Andy Sage. And the 8-volume series, Human Technology Interaction in Complex Systems. Among many advisory roles, he has served as chair of the Committee on Human Factors of the National Research Council, a member of the U.S. Air Force Scientific Advisory Board, and a member of the DoD Senior Advisory Group on Modeling and Simulation. He's been designated a lifetime National Associate of the National Research Council and the National Academies, so he's a member of the National Academies. Rouse is a member of the National Academy of Engineering and has been elected a fellow of 4 professional societies, IEEE, INCOSE, Institute for Operations Research and Management Science, as INFORMS, and also Human Factors and Economic Society. He received his BS, close by actually, his BS was from University of Rhode Island, and his master's and PhD were from MIT. So since Bill has done so much work in the systems area, he had just sent me his presentation on healthcare. I said, hey, you need to tell us all the great things that you've done over the years. So he's going to start out with...
Okay, thank you, Krishna.
Thanks.
Well, it's a pleasure to be here. I've never been to Yukon or the stores before, which is really rather amazing, given Rhode Island is, 30 miles away? You're very close to Jeremoth Hill, which is the tallest point in Rhode Island. It's 800 feet. And it used to have the Brown Observatory. It seemed kind of odd to have an observatory at 800 feet, but in Rhode Island, that's the best you can do. But it was recently sold to the state of Rhode Island to make it open to the public. So if you're feeling adventuresome and want to climb 800 feet, Jeremoth Hill is only 30 miles away. So before I plunge into healthcare in great depth, and you might wonder in advance, why healthcare? But what you're going to see in terms of the case studies I present is a lot of engineering models you're very familiar with that we've used to try to improve the healthcare system in the United States. Recently, I served on a working group for President Obama that produced a report on the benefits of system engineering to accelerate the transformation of the healthcare system in the United States. That report went into him last year. There were some people who claimed, I have no idea if this is true, that it's probably the first report ever received by a president of the United States that has system engineering in the title. But there's tremendous opportunity and tremendous need there. But first, let's start way back. I basically have had 3 careers. Started off as an academic researcher and educator, and I'll talk a little bit about the things I did, but started at Tufts, I went to Illinois, and then to Delft, and to Georgia Tech. And I took a leave of absence from Georgia Tech for 13 years and started 2 software companies, Search Technology and later Enterprise Support Systems. I came back to Georgia Tech in 2001 to head the School of Industrial System Engineering. They've been ranked #1 for 25 years now. And then came to Stevens Institute to help build a program there and start the Center for Complex Systems and Enterprises. Our School of Systems Enterprises is new enough, it's 7 years old, that the dean and I are the only full professors. All the other faculty are assistant and associate professors. We just hired another 6 or 7. And so the #1 item on my job description is mentor young faculty, which is a lot of fun, actually. So first, the University of Illinois in Mechanical Industrial. My research at MIT was mainly focused methodologically on estimation and control theory. So Kalman filters, optimal control, etc. But I was particularly interested in how you apply these when there are humans in the system, as Krishna has done for many years also, and how you understand the role of the human, the performance of the human, how to train and aid them. So I continued that work in Illinois. But because I was next door to the artificial intelligence group, they kept on asking me questions about how should or will people interact with intelligent systems. And worked on that for many years, as Krishna mentioned. The interesting thing about this, 2 sponsors who come to me recently, one of their questions is, how are people going to interact with driverless cars? Because it's not really imaginable that a driverless car will never encounter anything it doesn't know what to do about. So what's the role of the human? And interestingly, for cars, as opposed to jet fighters and nuclear power plants I did earlier, for cars, you can assume no training on the part of the driver. Okay, so all the smarts have to be in the car. And we focused a lot on that back here. We also did a lot of work on design of information service networks using queuing network theory for routing. I spent a year at Tufts and a year at Delft. There were 3 books that came out of this. I'm not going to mention journal articles because there's really not enough space on slides, so I decided to just mention the key books that came out along the way. So this is the first book, was an orange book. Some of my students used to refer to it as the Orange Peril, for those who weren't so mathematically inclined. And then I met Jens Rasmussen in Denmark, and we focused on this whole issue of how do people detect and diagnose system failure, particularly highly automated systems. What can we expect of them, of their ability to do it? And from there, I moved on to Georgia Tech. It was a very interesting experience being at Georgia Tech. They were much faster moving than Illinois was. From the time the head of the department asked me, send me a letter with what you need to say yes, I sent him on a Thursday, I express mailed a 5-page single-space letter, and on Tuesday he called me and said, when are you coming? The Georgia Tech was very decisive. We started a Center for Human-Machine Systems Research, again focused on human detection and diagnosis of system failures, but also human problem solving more broadly. And this has continued on to today, and I probably won't get to this later on, but we've come up with this notion of enterprise diagnostics, where the whole idea is you're looking at a large-scale display of your enterprise, and we've been focused on the automobile industry. How do you know whether the enterprise is running correctly? And if it isn't, how do you figure out what's wrong? And we've recently run some experiments on that, actually representing real automobile companies. We focus a lot on bibliographic information retrieval systems. I started the series that Krishna mentioned then, and did a book. Well, this was a book in honor of Tom Sheridan with other people. So we started Search Technology in 1980 in Urbana, Illinois. And the way the company started, we'd done all this work on intelligent training simulators. And one of the students in our group that wasn't working on that project had paid attention to that. When he got his master's degree, he went back to the company, Marine Safety International. And the president of that company called up and said, we've heard all about your intelligent training systems. How would you like to build one of those for real? For training power plant operators, super tankers. So we started the company building intelligent training simulators, and went on and did this for the Army, the nuclear power industry, the space shuttle, a lot of other companies. And we also had two very large contracts, the Pilots Associate with DARPA and the Designers Associate with Air Force Research Lab. Along the way, the people we were working with in other countries and NASA said, we really like the way you think about these problems. Would you be willing to teach us how you think about these problems? And it resulted in a series of books. This book originally was called Human-Centered Design, but then I remember I gave a one-week workshop at NASA Langley on this, and it was all about how to think about designing complex systems when there are people in them. And after the lectures were over for the class for the week, several students came up to me and they said, we think the title of your book is awful. They said, human-centered design, you have to think about what does that really mean, etc. And what you've got here is a methodology that will let you design any system successfully. Why don't you call the book Design for Success? So I got back to Wiley. They breathed a sigh of relief and said, yeah, that's a good title. And went on. Now the interesting thing, we had several hundred experiences with these companies, high-tech companies, Motorola, 3M, Digital, Lockheed, drug companies, etc. And at one point, some of them came to us and said, you know, you're helping us design our products better, and we like your methodology, but we've got a conflict with our business processes. The philosophy with your design methodology is in conflict with the way we run the business. So would you help us redesign the business? So whenever I have 3 or 4 customers offer me projects without even writing a proposal to solve a problem, there must be something there, right? So this led to strategies for innovation, business design. Catalyst for change was related to, we ran into problems that what the company was trying to become was in conflict with its organizational belief systems. And so people were not buying into, they were buying into it intellectually, but not in terms of day-to-day activity. And that led to a book called Catalyst for Change. These are all with Wiley. And then finally, system design, and that was with Elsevier. We did a study of the psychology of design. How are designers thinking about when they're designing airplanes? How do they use information? How do they make decisions? And this one was with Ken Boff. So after I wrote these books, it's kind of interesting. I give these lectures, and at those times they were a week-long course, a 3-week course, all over the world. People said, you should write the books. They said, you're a college professor, you should write a book. And so I did write the books. And then they said to me, well, we like having the books, but we don't want to really read them. Can't you develop some tools that inherently embody the philosophy and methods in the books? So we know when we're using your tools, we are following the books without having to read them. So, okay, that led to a new company, Enterprise Support Systems. And our advisor series, our best-selling product was the Product Planning Advisor, which was a combination of multi-attribute utility theory and quality function deployment with a little bit of AI built into it. Then we had a technology investment advisor, which was real options theory and some other methodology. Situation assessment was totally AI-based system. And the business planning advisor, this is very difficult to compete in that space because there were so many. This was our big seller. We sold thousands of copies of this and associated services. This led to a series of books that were more business-oriented. One of the things I found, you're always in the mode of trying to sell a project or sell an idea, at least I am. I've always got this set of ideas I'm trying to get funding for. And I found out with the other books that whenever I went into a company and the CEO said, oh, I read your latest book, I really like it, then we got a sale before I even did anything. Then I had to give the presentation, but they were already bought in. So I led to a series of books that were more business-oriented. This book relates to planning and how plans go awry, and I won't bother to go into details. This is assessing where you're at. One of the things I discovered, the companies often could not execute their plans because they were no longer the company they thought they were. And they no longer had the position in the market. Don't Jump to Solutions, the subtitle is 13 Delusions that undermine strategic thinking. And I basically discovered how these 100 companies I work with deluded themselves into thinking they could succeed at a plan that they inherently could not succeed at, but they would not admit that things had changed. And I brought this all together in a little more academic book with all sorts of methods and tools. One of my philosophies is in conflict with Harvard Business Review. There isn't just one 2x2 matrix that solves everything. Okay? There's a whole wide range of methods and tools you can to address different problems. You need to have that portfolio. So from there, I had decided, after these years in business, that at some point I wanted to just transition back to academia. I had a chance to become the school chair at Georgia Tech and start the Tenenbaum Institute, which was focused on solving the problems that I had identified while working in industry. In these two positions, we raised $40 million of gifts to fund the research and had other projects too, and led to another series of books. These were two edited books. What I was concerned with here was establishing us as thought leaders. So what I did was to get all the other people who were thought leaders to be in the books, so people would give us probably more credit we deserved. And then this led down. Final book, this was written with the CEO of Mayo Clinic, Dennis Cortese. And I'll come back, you'll see that book again later in the healthcare talk. And then finally, on this introduction, I guess this is sort of the overture, right? I took this chair of economics and engineering because the recent two books were on economics. I began to understand economics much more deeply than simply discounted cash flow and stuff. Become director of this center. Led to an edited book on complex systems, and then these two books that Krishna mentioned recently. I taught this book this spring, with graduate course this spring, with 11 PhD students. The subtitle of the book is Explorations of Physical, Human, Economic, and Social Phenomena. The idea is to get our students to understand what is the state of the art of how we understand systems in a very broad way when there are important behavioral and social components to that system. So unless there are any questions, it's hard to argue. It's just a list, right? I'll dig into healthcare. At least I think I will.
Can you go for it?
Not being a Windows user.
No, she's got it.
Okay.
She's got too many things open.
System is freezing.
Oh, I'm glad you had difficulty too, then I'm not dumb.
Oh, okay, it's big enough, probably.
We're actually not using that. So.
Weird.
You can just close this one, can't you? Up there.
Yeah,
You get
it's
rid of it?
actually-
Oh, you can't get the mouse to move. Okay. It's obviously not going to do that cable. That's just the display.
That's the problem. It's already out.
Let me just do the brief sure of this how I got involved with healthcare.
Still working.
It's extended.
So the Institute of Medicine published several studies, late 90s, early 2000s, on crossing the quality chasm to air is human. And they're about medical errors in hospitals and the poor quality of care. Medical errors, as I recall, the last statistic I saw, about 100,000 people a year die in U.S. hospitals by mistake. So Andy Sage, who I just mentioned, passed away last year at Halloween. He just had his celebration service May 1st. He went to the hospital for hip replacement. He was 82. While he was there, he got an infection, had a heart attack, came home, lasted a few months, and then died. About 100,000 of those kind of things happen. Infections is a big problem in hospitals, especially for older people. Older people, you want to go to the hospital last resort. Younger people, you're more resilient, but then you don't have as many reasons to go to the hospital. So based on these studies, the Institute of Medicine contacted the National Academy of Engineering and said, we think that that you can help us with your engineering techniques to improve healthcare delivery. And the first result was, I guess it's working, it's okay.
Well, we'll be fine in the next slide. Yeah.
No, it's fine. Okay.
Yeah, it's fine.
So the first result was in 2005, report on engineering the healthcare delivery system. And it actually wasn't the actual title of it. And that was sort of a starting point of how can engineering come to improve healthcare. I've worked now in a tremendous number of hospitals and providers. And so I know the inefficiencies are amazing. The poor use of capacities is a major problem, and I'll tell some stories along the way. But I get involved, I think the next year after that, I was doing the work on enterprise transformation, and Paul O'Neill, who was the Secretary of Treasury, was the former Secretary of Treasury, former CEO of Alcoa, asked if I'd come to a workshop he was running out in Irvine and talk about transformation of the healthcare system. And I'd been thinking about it a bit, put together a fairly overview talk, because it was all medical science folks, not system engineers. And gave this talk, and interestingly, one person in the audience raised their hand, and they said, well, if you totally transformed the healthcare delivery system in the United States, how would you run the randomized clinical trial to prove that it worked? My answer was, that would be the last thing I would do. First of all, how are you going to get a variance estimate when you're going to end up 1 within your paradigm? But there's no reason to do that. And as you'll see here, these are the series of things that emerged from that. I went on and chaired a variety of activities, the National Academy's Healthy America Initiative, the Engineering the Learning Healthcare System program. And interestingly, I'll get to this later in my talk, we found out for the engineers to communicate with the head of healthcare people required another level of representation. And I'll show you that in a minute. And it really drove us to try to be innovative, because we knew we're talking to Institute of Medicine members. These are really smart people and very influential people. And if they don't understand us, it's our problem, not their problem. And so you'll see how this evolved in this talk. So we're going to talk about the kind of system that healthcare delivery is, and how healthcare delivery fits into that. Then we're going to go through 5 case studies. We're going to talk, well, if healthcare is a complex system, the natural question, the doctors have never asked, but as an engineer I had to ask, well, how complex is it? And you'll see the answer is 27 bits. You'll see what that means. What about cost control? Well, we could maybe control costs if we had a learning healthcare system that got better and better all the time. As an engineer, I would inevitably ask, well, how much would we have to learn? Okay, I want to quantify these things. So, well, one way we can control things is have price policies, price controls, which never work, and we'll show with this a little bit of math why they can't possibly work in healthcare. And then finally, we're going to look at the broader enterprise. How do we think about this more broadly? Because the decision how to treat patients is based in a whole context that goes all the way up to CMS, Center for Medicare and Medicaid Services, in terms of their policies and rules. So there's a whole bunch of things that cascade down. And then finally, we're going to look at how healthcare providers have been responding to the Affordable Care Act. And you'll see here how we simulated the whole healthcare ecosystem of New York City, 66 hospitals, to understand the interactions among these hospitals. But let's first start off with complex adaptive systems. So one of the questions I often get asked in the beginning is they say, wouldn't the healthcare system be better if we just made it a system? That's the problem, it isn't a system. And the answer, of course, is it isn't a system like a car, or an airplane, or a factory, or a power plant. Those are all engineered systems. The healthcare system emerged. It was more of an emergent system. And it's a complex adaptive system. It's not an engineered system. The key point here is the red. I guess we're losing a little bit of the black, but the red is all that matters. Okay? So the systems are nonlinear and dynamic. They do not inherently, their outputs are not necessarily linearly related input. There are a bunch of independent agents. They have goals and behaviors that are likely to conflict. The provider and the payer are in complete conflict with each other. The payer wants to get that procedure for as little as possible. The provider wants to get as much payment as possible. The agents are intelligent and learn. They're self-organizing, and there's no single point of control. You can't just go and tell the system it has to do this. Command and control won't work. So, healthcare is a complex adaptive system. Cities are complex adaptive systems. Higher education is a complex adaptive system. As much as you may not necessarily agree with this, the higher education system, the University of Connecticut, there is really nobody in charge. There are some people that have an enormous amount of influence, but they can't. I don't know if you've ever tried any of this. You just can't tell everybody what to do.
I know that.
Yeah.
He has experience.
Okay, so let's talk about how is healthcare like this. So one of my projects in the second company we ran, one of our users was the American Cancer Society. And what often happened when these customers used our tools, they began to bring us problems that went way beyond the tools. And so the Cancer Society asked me, how do we invest our $500 million a year? Our constituency wants us to invest it in basic medical research, but NIH is spending like 16 or 20 billion a year. We're a drop in the bucket. Maybe there's someplace else we'd have more leverage. So let's look at the system. So here's the stakeholders and interests. You've lost a column over there, but you'll get the idea. We've got the public, the delivery system, government, nonprofits, etc. And we've got how risk is managed, how we deal with prevention, detection. This is the treatment column. Okay. There are a tremendous number of stakeholders involved with this. It's not like you can just go and talk to the doctors. There's also a value stream, okay, here. So, for example, with disease detection, in order for screening to be effective, you have to have the public aware and ready to use it. I mean, you can imagine, for example, the first patient to get a colonoscopy would say, "You're going to do what?" Right? I mean, the procedure was not readily acceptable. Then we have to have the physicians able to screen for it. We have to have somebody willing to pay for it. And then we have to have the system.
You can try to see, fix it.
Okay.
It is I think it's too much resolution compared to the projector.
Okay. So the thing we were doing with these slides was orchestrating a discussion with the executives of the American Cancer Society of where does value actually happen and where can you uniquely add value. And if you put all your money into medical research, for example, consumer advocacy is dramatically underfunded. And that would be a place where you could better invest your funds.
All right. And then the second one.
Yep.
Looks like you're taking up a little more screen. So these are the words you missed. Okay, and here's where we are. Thanks. Thank you very much. So here's the column that you missed. And then the other thing is rather obvious. Now, in this process, these slides are from years ago, but I get invited to a few meetings to look at the future of medical education. And actually, right now, we have a proposal pre-proposal into the American Association of Medical Colleges, because I was invited to a meeting in April where it was university presidents, provosts, deans of medical colleges, and one engineer, me. And the problem they were looking at is, as we go to the outcome of the Affordable Care Act and bundled payments, the bundle is then a pie that has to be divided among all the care people, which is going to be a care team, not just a specialist. It's inevitable that specialists' incomes will go down. They won't get as much of the pie as they get now, because you can't bill by procedure. Well, medical schools are concerned that the doctors will no longer be willing to graduate from medical school with $300,000 in debt, because they're not going to have the kind of income that could pay that off easily. And there's been a variety of approaches to how to deal with that. So we're suggesting that we use our simulation techniques, which I'll show you in a minute, to simulate the entire health education system in the United States. There's 141 medical schools, 400 teaching hospitals, 150,000 faculty. By the way, there were 25,000 engineering faculty, 150,000 medical school faculty, and $500 billion of revenue involved. And the question is, how do we look at alternative schemes for training physicians? But that's another topic. So one of the questions here that I assumed in this earlier work was that there were physicians. Of course, they're physicians, right? You have the people to do the job. But one of the meetings I get invited to, as you start to do this, you get invited to all sorts of meetings, which is sort of like an education in itself. Okay? And the question is, where do physicians come from? Obviously, they're born as little kids and grow up, but how do they get to be physicians? And at this meeting, I started writing down every organization I heard of. There's many more that are associated with the accreditation of medical schools and the licensing of physicians. It turns out many of these are different in each state. So if you're licensed in Connecticut, you can't go, I don't think, and practice in Massachusetts. So there are hundreds of other organizations associated with just the existence of physicians. So this is a very, very complicated system. So let's dig into the case studies. So the first one, people said, well, healthcare is a very, very complex system. That's the problem. And my concern was, well, how complex is it really? So we developed a model of the healthcare system. This is a very high level. Each of these nodes has lots of nodes in it. Here we have the consumers interacting with the providers, the pharmacy, health insurance, etc. R&D organizations, government policymakers, etc. And I'm sure, since you're all related to engineering, you'll see that immediately looks like that. And so now we have a hierarchical network. Okay? And what I was interested in, when you ask the question how complex a system is, and I ran a series of 8 workshops, I ran this up on this. My position, and most people agree with me, that complexity is a relationship between the observer and the system. Okay? If I buy a Boeing 747 and use it as a paperweight, it's just a large mass. If I want to fly it and maintain it, then it's much more complex. Okay, so I have to say, why do I want to know the complexity of the system to define complexity? And I'm going to say for a random transaction out here, a randomly selected transaction, the state of this system is the nodes involved in that transaction. Who provided the Band-Aids? Who provided the sutures, etc. So then I have to probe this network to find out who's involved. Well, given I have a lot of data about the probabilities of these arcs, I can then use Shannon entropy and calculate the complexity of the healthcare system. And this is where I get the 27 bits. To figure out the nodes involved with any random transaction, we take 1 billion binary questions. So 27 bits is large. But the question is, how complex is that compared to other systems? Because I need a baseline. So we did the same thing for other domains. By aerospace here, we mean taking a flight. We don't mean building an airplane. Buying a car, not building one. Retail, Walmart, Target. Healthcare, and then telecom is getting this telecom service. And blue is the proportion that the consumer needs to deal with. So now you see retail is more complicated, more complex than healthcare. And you say, how can that be? In fact, this is a common comment from audiences who are in healthcare. I say, first of all, retail is half of the Fortune 1000. There's just so much. I mean, think about how many retail stores there are in a city versus hospitals. Okay, so that's one reason. But people still object, how can you compare healthcare and retail? So my answer now that seems to work is that, okay, let's say that retail operated like healthcare. So you go to Walmart, you buy that $29.95 toaster, and 3 months later you get 12 bills for everything in the toaster. Okay. You even get bills for things you could not imagine were in a toaster. Okay. That's how healthcare operates. Okay. Retail has conquered that. In fact, they never were that bad in the first place. So retail is an enormous success story. Michael Tenenbaum, who was one of my main benefactors at Georgia Tech, used to own Party City, and he told me the supply chain problems were big. Everything came from China. He had to purchase it there, get it there via supertanker by cargo ships, get it on his shelves, all organized and labeled, and sell it to you for 38 cents and make a profit. The whole supply chain sophistication in retail is very, very, very good. Healthcare could benefit from that. Now, telecom looks pretty bad there, but has gotten much better with the iPhone. Some of you may not remember pre-smartphones, where basically you'd have a problem with your phone, you'd have to call up, and the people you'd talk to would expect you knew all the guts of what was in your cell phone. Well, which chip do you have? Yeah, I never knew and didn't want to know. But healthcare, the telecom, has got much better. Healthcare is seeming to go the other direction because they're asking the consumer to do more and more to manage their own healthcare, to be aware of more and more things. Although there are online sources of things that can help now. Now the strategy, and when I've given this talk in healthcare, people have been amazed, is the way to get this blue bar down is to get the green bar up. In other words, we should increase complexity where we know how to manage it and reduce the complexity for the physicians and the patients and their families.
Just like retail.
Just like retail did, exactly. But how do we do that? Here's some implications. With our traditional system, we have a role in management. It tells everybody what to do. It monitors their activities. It's concerned with efficiency. There's contractual obligations. There's organizational design. It's hierarchical. Complex adaptive systems like hospitals or healthcare and universities can't do that. Cities you have leadership. You create incentives and inhibitions, let people adapt to those. Things you reward, things you don't want done. Or you can look at outcomes. You can't look at what everybody's doing every moment. You have to be agile. In fact, if you have a system that's totally optimized for one set of assumptions, one business model, it tends to be fragile as soon as those assumptions are violated. Where an agile system has some slack. Personal commitments, hierarchical flow, self-organization. We did a project for IBM on the efficiency of their design of servers. And one of the problems they have, each server, each generation is in the market for 3 to 6 months. And the first month is when you make all your profit. If during the process of designing that server, they have to go to a higher level to either get permission to do something or get resources, it costs a week per level. If you're a month late, you lose half the profit on that product generation. Okay, so the hierarchy, getting the decisions down lower, make a difference. So what can we conclude from this first case study? Healthcare is a complex adaptive system and highly complex, but not as complex as retail markets that manage complexity to minimize the burden on consumers. Convenience is very, very important. We want to increase overall complexity where it can best be managed in order to decrease complexity for patients and clinicians. Information management is a key issue, as is creation of incentives and inhibitions that will motivate stakeholders to provide quality, affordable care for everyone. So the next issue I started to dig into was, why is it so expensive? Why is healthcare so expensive? There was a Congressional Budget Office report that says the present GDP for real healthcare costs in the 40-year period tripled. 50% of the cost growth is attributable to technological innovation. Pete Peterson wrote this book on Running on Empty. The system simply cannot continue the way it is. It's interesting that technological innovation in most industries reduces costs. In healthcare, it increases costs. We'll show you why in just a second. We're going to try 3 models. I should say, by the way, most of the modeling I do, maybe because of the stakeholders I'm dealing with, often just starts out with simple algebra and a few little equations and some predictions, and then the stakeholders will say, no, that's too simple, and we add some more things on. But they're with us along the way then. So let's look at our models. Well, first of all, let's outline the phenomena. So we have a technological innovation. Over time, it becomes more effective, it becomes efficient, and the risk goes down, the risk of it failing. So sensors, stents, pacemakers, etc. Okay. Because of increased effectiveness and decreased risk, we get increased use. That would be good if we were selling iPhones, but if you're the one payer for all the Medicare patients, that's not necessarily good news, economically at least. Because of increased use, we get improved care, people live longer, and they get back in line. So for example, the average number of hip replacements in the United States for people who have hip replacements is greater than 2. They come back again after 10 or 15 years and do it again. At the same time, our increased efficiency, we get a decrease in cost per use, asymptotic down. We get exponential increase in use to come together to get increasing expenditures. So as we're making it down this slope, it's almost impossible to keep up with this growth. And that's the problem. So the healthcare, and simplistically, the total cost of healthcare is the cost per use times the number of uses. You can get the cost per use down, or try to get the number of uses down. So chronic disease management and stuff that I'll talk about 2 case studies from now, we'll deal with this issue of how can we get it so people don't end up in a hospital so often. So here's about as simple a model as you can have. If we're going to have an annual rate of increase of beta, and maybe we're going to allow an increase for GDP, then I'm going to decrease my cost per use by alpha. And I solve the equation, and so here we see, these are the real rates over 40 years for these particular maladies. You can see, I mean, something like 1.15 to the 40th is a pretty good number, right, in terms of use. So we'd have to get rather substantial reductions, in the order of 10% a year in the cost per use. The problem with this model is there's no mechanism for achieving the cost reductions, and it doesn't differentiate any model, any part of the process. So let's add production learning. Now, this has been around for a long time. The work we've done in semiconductors, automobiles, and I also know in airplanes, the whole notion of production learning is how you actually make money. And the basic thing is that every doubling of uses, your percent cost goes down to 70% of what it was. So what happens with semiconductors, for example, is they produce millions and millions of these. Their cost of a semiconductor goes way, way down, but you're still paying the same price. And Intel, et cetera, are doing quite nice. So we're going to apply this to our healthcare problem. We're going to assume production learning by doing more of these procedures. They should get cheaper. And so here we have the cost per use for 3 learning rates, 70, 80, 90. And you can see the higher the learning rate, the faster it goes down. Against a low number is high, right? And a low number is better because that's the subsequent cost. And we get expenditure growth 5, 10. So these are the key results here, just nominal results. Basically here, we've decreased the cost per use to 24% of what it was, yet our overall cost is quadrupled. Because it's so attractive, people are increasingly using it, like hip replacements, knee replacements, etc. The model exhibits impressive cost reductions, does not suggest where and how it happened. It does not reflect the process whereby healthcare is delivered. So let's go one level deeper and break the process down and break out labor and technology. Because technology efficiencies, we know how to model. We've got huge amounts of data on it. Labor efficiencies are another question. So now we get a bit more algebra, because I got to break it down by labor and technology. And but the key thing here are these results. If I can constrain growth of use to 5%, and GDP is running at a 4% growth rate, I need a 72% learning curve for labor. That's imaginable. That's been done many times in many industries. On the other hand, if I get over here, and I have 0 GDP growth, and 15% growth in use, I need a 40% learning curve. No one has ever achieved that anywhere. So obviously GDP helps here, but also restraining growth rate helps. Now, let's talk about the implications and then how would we get this learning. If we limit the growth of spending. We either limit the growth of technology use, we limit the cost of technology use, or we decrease the labor associated, the cost of labor. For example, one thing we can do is get you to manage your own healthcare. Like you book your own airlines and you buy your car online. Nevertheless, that high learning rate is very hard to achieve. Now, the Commonwealth Foundation came out with an economic study of this, and so we're not really we're being reasonable. Less labor per use. We can do this. We can use different kinds of learning productivity. Less expensive hours per use. So you don't actually get to interact with your primary care physician. You interact with the care coordinator first to see if you actually need to see the primary care physician. No labor per use means you do a lot of it yourself. And a lot of the things we've worked on, the patient takes on an enormous amount of responsibility, but it's with a user-friendly app that sort of knows you, and it can be done well. The Commonwealth Fund came out with an analysis with health economists saying, here's the ways we can bend the curve to get the growth down. And they all pretty much map to our recommendations to how to reduce rates. So it's achievable, but there is a big but here. Successful technology innovation leads to growing markets, increased revenue to the innovator, the iPhone. But this problem we have is we've got Medicare paying for all this, one payer. And they don't necessarily like innovations that increase costs. We need some market-based mechanisms rather than just third parties. Some of that's coming in. But the required improvements, especially in labor costs, are enormous. Now, the other irony is that, for example, Pittsburgh, healthcare is the largest employer. In New York City, 7 of the largest 25 employers are healthcare providers. The healthcare system provides an enormous amount of jobs. So we haven't looked yet at the economic consequences of actually succeeding in controlling costs, because it bubbles over to other things. Now, another way to handle this is just control costs. Say, that's all you get. We're not going to pay you any more. And so this model, we have a market with suppliers, providers, consumers. The consumers, it's dotted because every once in a while I get to vote for the government, but we don't bother to put that in the model. And the policy objectives are to maximize demand and minimize cost. They can do this by fixing certain policy variables or constraining them to stay less than some max. The elements they can control was demand, prices could be a function of cost. They can affect profit via taxes, and cost of capital via interest rates. So the government has several levers here that they could employ. The stakeholders, consumers want their decisions are based on how much they can spend. Providers, suppliers are similar. Price, how much to produce, how much to invest. So then we start with a little basic microeconomics. We have a production model here, a price sensitivity curve. The number desired is sensitive to price. The profit is number of price times number desired minus price times number produced minus fixed costs. There's an economy of scale as you produce more of these nice simple linear equations. And then we estimated the fixed cost as 1 minus the gross margin times the number sold. This is a very rough approximation, but it makes the thing tractable. And then with a whole bunch of, there's our cost sensitivity and curves, price sensitivity and economy of scale. Then with just a lot of pages of algebra, we get that the optimal pricing is this. The maximum profit when this occurs, or minimum loss when this occurs. So this would say, from a microeconomic theoretical point of view, this is what people want to charge. As alpha goes up, it goes down because the market's price sensitive. As you get more beta, is your economy of scale. As you get more economy of scale, the optimum price goes down. This is how profit goes up as you get more efficient, goes down as the market's more sensitive. So then we look at a policy scenario. Let's say the producer is operating with those values, alpha, beta, and GM. Their optimal price is 3.16. They're selling this amount, and the government says, no, you can only charge 2.5. Well, then what happens? The price is obviously fixed. The quantity goes up, but the profit goes down. You have a 10% loss of profit. What will the provider do? Now, when Medicare has set these prices, they're assuming the provider will invest to become more efficient because then they can make a better profit with that efficiency. However, that's not necessarily the case. You can see here the fraction of profit lost. So, what's my alternatives? Well, I can reduce alpha by, for example, an advertising campaign. So one of my favorite you must be inundated with these advertisements on TV to try to convince you have these various maladies, right? One of my favorite ones, and I forget what the drug is for, but the end of the ad, it says, may lead to severe depression and suicidal tendencies. If this is not normal for you, contact your physician. But they could advertise. They could advertise to try to get more demand. They could increase beta by increasing productivity in the near term. They'd have to invest in the long term in R&D. And where's this money going to come from? They could reduce the gross margin by reducing GA, R&D, etc. So the easiest way to fix this problem is to strip out all discretionary costs. Get rid of your general administrative costs. Get rid of R&D completely. And on the short term, this actually works really well. The problem is in the longer term, you don't have any innovations to sell. And you can see here, should I increase millions of dollars and become more efficient? I got to really move a lot to get the payoff here. Or what if I just cut costs dramatically, immediately? You can see very small changes make a big difference. So again, we have our three strategies. The key is it all depends on the alpha, beta, and general gross margin of the company. Now, interestingly, this is an interesting way to do these kinds of papers. There's a tremendous number of papers on health economics that address this issue. But I developed the model not having read any of that. And then I sent the paper to my colleagues at Mayo Clinic. And they sent back and they said, okay, for this point, cite these two papers. For this point, cite these three papers. For this point, cite these two papers. So the paper has a nice set of health economics literature. But I kind of like the idea of doing the model independent of the empirical findings and then seeing how it aligns with the empirical findings. And what you find is people are doing all these things. With one addition, if the return on invested capital is less than the prime interest rate plus risk-free interest rate, they exit the market. Something like 38% of the hospitals in the country are considering eliminating their emergency room. Several hospitals have got rid of obstetrics. Anything where the margin they can't make, they just stop doing it, which is obviously not very good for the patient. Okay. Now, the healthcare enterprise. Now we want to look at this question in a broader way. And we're going to talk here about a problem. Emory University provides prevention and wellness to their employees, actually to a subset of their employees. And they wanted to scale up from 700 people to 60,000 people, the employees and their families. And in fact, working with Emory, Vanderbilt, Indiana Health, UPenn, all four of these problems we've worked on is a scaling problem. Is the question that they've proven something is beneficial to patients on a very small scale, and now they want to offer it to everybody. But they're concerned that little inefficiencies with 700 people can become big losses with 100,000 people or more. And they didn't know how to approach it. So this is a pretty natural question for engineers with modeling and simulation tools of how do you scale. And that's the basic problem we've looked at. In all of them, we start with this model. Okay, there's a level where you have clinical practices, physicians, clinicians interacting with people. Above that, you have delivery operations. It delivers capabilities of information, and it captures outcomes, health outcomes, and patient information. Above that, you have organizations that have competitive positions, economic investments, economic returns, and performance information returns. Now, in many hospitals, we've done a lot of work with Piedmont Hospital, Atlanta. While every door will have Piedmont XYZ as a service, those are all separate companies. They're basically just franchised by the Piedmont Hospital. So they have a great interest. If all they own is an MRI, They want MRIs, right? That's pretty natural. And then above this, you have the health ecosystem with an economic model, incentive structure, and human productivity and healthcare costs. Right now, within our healthcare system, within Center for Medicare Services, they attach no value to people being healthy and at work. They simply want to minimize what you cost them. But of course, being healthy and at work generates productivity for the employer, generates income tax payments, Social Security payments, but the system is so siloed, they don't look across that. And in fact, the way it works is we have, at all 4 levels, we have various networks operating. So the 2 scenarios we look for at Emory was continued price controls. In other words, you just get paid per procedure. And what happens is the decisions are regard procedures and trying to maximize reimbursement. You have procedure-oriented processes, and you have available procedures and patient disease progression models. When you have pay for outcomes, then you're concerned with interventions that optimize outcomes, not maximize reimbursement, because you're reimbursed for the outcomes. This is a very strong trend in the country. Your doctor's not going to be paid for giving you procedure X, Y, and Z. He's going to be paid, or she's going to be paid, because you're healthy. He's going to be paid more if you use the healthcare system less. But you have to be healthy for it. You can't just let you lay there. Right? There's other things. So with outcome-oriented processes, available interventions. So then what we get to is a set of models. Okay, rule-based models, microeconomics, queuing networks, decision theory. Over there, on the red is what's different between the 2 sets of models. And then we get the flow of the variables between these. You'll see a lot of things that you're familiar with. And we can populate these models with lots of things. We're very, we just include every possibility. There's not like one set we use, but you can see there's a tremendous number here. And what we end up with for Emory is this is their simulation dashboard. So at the ecosystem level, this is the VP of HR. He can make some choices. It was a he in this case. At the organization level that provides the care, they have some choices. You'll see there's 2 more levels. So they can decide, do they pay a fixed amount per patient or do they pay by outcome? Because this is prevention and wellness, what they're doing is reducing risks. So you actually get paid to reduce risks. They can talk about what the capitated payment is, what they assume for inflation of the healthcare or the economy, discount rate. They can decide which data set to use. They can use national data sets or they can use Emory's data. This was an unfortunate choice of words. It just means when we end the simulation at 65 or at 80, you'll see this makes an enormous difference. Down here at the organizational level, they're trying to reduce the risk of diabetes. They can vary that. They can have the percent annual risk reduction. We have to stratify the patients to high risk and low risk. Same thing for heart disease. Length of the program, growth rate, entering age, etc. So they have these parameters. So if we were to run Emory's program as it was, and you'll see this again in a minute, they would have a minus 96% annual ROI lost. You don't get much worse than that. Now, one of the people we put into the display was the people level, and these are all the patients, either existing ones or projected new ones in the system, and what they're doing. This is a new arrival, they're in visit A, they're in visit B, they're in execution, facilitation, health coach mode. And this is just a snapshot at one point in time. But one of the interesting things we found from this was the physicians were just attracted to this display. And they said, those are what our patients are doing? I said, well, yeah. I mean, basically, for the past patients, we have it by every calendar day and everything. But they said, this would be so cool if we actually knew what people were doing. Like which of our patients are in the clinic today? They actually don't have an easy way, one screen, to say that. Now, what they were actually doing, and for the medical people, this was a little unusual. They didn't think about it this way at all. Okay, but they have an assessment and goal setting level. They have execution and facilitating, here's your health partner. They have a maintenance mode. And these are all the things that happen, and these have costs and probability distributions and transition probabilities associated with them. So what we get out of this is we were able to convert a minus 96% ROI to a plus 7% ROI by computationally reorganizing. So basically, human resources will be making money off of their employees. And you can see here, pretty steady difference. Now down here, the provider is very spiky. Sometimes they make a lot of money, sometimes they lose money. So they would naturally ask us, well, why is that? We said, let's go back and look at the patients flowing through the system. When you get someone with a very high risk of diabetes, a high risk of heart disease, their procedures, the processes I showed you, dramatically improve those people's lives. Dramatically lowers their risks. When you get people coming through who have the lowest possible risk, you can't lower anymore. But they did the same thing for those people. They had this egalitarian idea that we'll do the same thing for every employee. Well, it turns out for 90% of the employees, this is a complete overkill. And for 10% of them, it's highly valuable. So what happened in these green spikes is you had several people come into a very high risk that year. Okay? And they finally, after looking at this, I remember the day, because we had argued this before, they wouldn't hear it. They said, seeing that, maybe we should target high-risk people. Yes. Of course you should hire high-risk people. That's how you're making your money here. And so they decided to stratify the population and look at it in a different way. And these are the kind of things we've done for several providers now. So minus 96% ROI, but they're having dramatic improvements with people with high risks. We radically reorganize it, we get a 7% high. The idea of computationally reorganizing it was totally foreign to them. In fact, I said, how would you normally approach this problem? They said, well, we'd have the key stakeholders and other people from the medical school advisory board sit around and talk about it a lot. And then we'd decide what to do, and we'd roll out the new organization, and 3 years later, we'd measure whether it worked or not. Where we were actually exploring hundreds of alternative organizations in an afternoon. Now, if we extend the analysis from age 65, when they were nominally retired to Emory, to age 80, we get a 30% ROI. This is all to the benefit of Medicare and Medicare. Okay? In principle, at least, CMS should incentivize Emory to provide prevention and wellness to its employees. In other words, we should incentivize employers to keep the population healthy so when they enter Medicare, they're healthier. It's a very straight, and it's of course better for their lives too. But even just purely financially, it makes sense. But with the way our system is siloed, there's no way Medicare can give an employer a tax advantage or some tax credit. It's just, our system doesn't work that way. It's very siloed. But we need to incentivize employers to keep people healthy. So when they enter Medicare, they're in better health. Okay, last case study. So the Affordable Care Act, I had the good fortune a year ago, August, to be the lead-off speaker at a meeting of healthcare CEOs on basically how to think about the transformation of healthcare. After that, 10 CEOs presented how their strategy for addressing the Affordable Care Act. Okay, the head of the CEO of Partners in Boston, the CEO of Barnes in St. Louis, and et cetera. The reason this is important is the Affordable Care Act is going to go to bundled payments. So you only get paid for the set of things you do for achieving certain outcomes. It just totally changes the cost model for the provider. They're used to just cost plus. They just get reimbursed for the activities. More activities, the better. And the system isn't going to work that way. So what we did is we looked at, okay, for all the players in this, the insurers, the hospitals, the drug companies, patients, et cetera, what are their choices? And we worked out all these different choices, and I won't bother to go through that all right now. But what are their choices? And then we went back to the CEOs, I think we talked in the end to about 20, and said, given all this is happening, what are your choices? And they came back with this. Well, we can acquire other providers and physician groups, get access to greater market share, achieve economies of scale. Because one of the things that's happening, which is really great news, is with chronic disease management, the incidence of people going to the emergency room or to inpatient admissions is steadily going down. Hospitals have empty beds. Well, what do you do with the empty beds? You can get rid of them or address a bigger catchment area. And that's what they're doing with buying up people. Also gain capabilities to address more profitable GRDs. For example, cardiac surgery and orthopedic surgery are very, very profitable. And so if you can gain people that have those diagnostic-related groups, you can make money. Invest in creating, in these highly profitable diagnostic-related groups. Get rid of the marginally ones. If they lose money, stop doing it. Invest in population health, accountable care organizations where providers are paid patient-managed per month fees plus bonuses. So what's going to happen in a lot of these is the doctor or the practice is going to say, okay, we're going to take care of these 1,000 patients. And the Medicare system is going to say, okay, you're going to get, I don't know, some $5,000 per patient per year, period. That's all you get.
Right.
So now you get $5 million, and you're going to manage those patients. Well, now it's really in your interest, those people not getting sick. Right.
I think that's being practiced right now, I think.
Oh, yeah, definitely. I could invest in improving the efficiency, integration, and delivery part. This is very expensive. It takes a long term to pay off. I could also invest in developing health plans. I think about a third of the major providers in the country are becoming their own insurance companies also. So Geisinger in Pennsylvania, they have the insurance company and the provider. The way they became so efficient is they're all under the same CEO. The insurance company got together with the providers and the doctor and said, look, any dollar that you can save by becoming more efficient, we'll give you half of it. It's amazing how much more efficient they became. Because suddenly it was in their interest to do this. So we created, this is the immersion lab at Stevens. It's 8 foot by 20 foot, 180 degree screens, all touch sensitive. This, by the way, is CEO of one of the Accenture companies. And Annie Yu, who's now an assistant professor, she was a PhD student, has developed a simulation of New York City. And this is all 66 hospitals in New York. And what she's trying to simulate as to who is going to buy who. Okay? And the concern is not to predict, because it turns out it's very hard to predict who will buy who, but we can predict how many will be left. We're able to show the huge path dependence of this. Whoever, like the Hospital for Special Surgery just does orthopedic surgery, very, very profitable. Whoever buys them first changes the game for everybody else from then on. And so the hospitals are here. These are the hospital attributes. So Annie needed the income sheets, income statements, balance sheets, operational performance, quality metrics for all 66 hospitals. None of them would give it to her. So what she did is she went through public filings for CMS, AHRQ, other places, and she reverse engineered the filings. So she had income statements, balance sheets, et cetera, from all hospitals. So all of these hospitals, the 66 agents in this agent-based simulation are making decisions based on this metrics. It's more complicated than I can explain right here. But we now have some of the hospitals wanting to use this to actually make their decisions. She looked at different strategies: maximize revenue, maximize profit, turnaround. There's a lot of poorly performing hospitals in New York. In fact, you can buy them for zero if you just assume they're dead. And so you could go into the turnaround business. So we presented these results in more detail at Columbia Presbyterian a month or two ago. And they are the largest hospital in New York City. They have been the largest hospital for a long time. And we showed them that under most scenarios, they're still in the top 5. But there were a few scenarios where they drop out of the top 5. The audience was aghast that they would no longer be number 1. We said, okay, it all depends on what strategy you pick and what strategy your competitors pick. And if you pick a poor choice relative to what they picked, you'll end up out of the top 5. And what's interesting about it is they actually were so self-confident, I guess this is just the hubris. They felt that whatever they did would keep them dominant. It didn't depend on what anybody else did. It turns out it's very sensitive to what everybody else does. So the conclusions, we used to be 644, now it's 66, but the result is the same in the end either way. We'll end up with 20 enterprises, not hospital facilities. They're not going to disappear. They're going to belong to different corporations. Okay? With a few exceptions, the remaining 20 are path dependent. There's no guarantee you'll be in the remaining 20, depending on what everybody else does. And once the hospital prospective surgery is acquired, the relative attractiveness of the remaining acquisition targets change. So the way we validated this model, if you will, is we predicted past acquisitions pretty accurately. And we also had a tremendous number of experts in this field come through and give us their comments and suggestions on it. Now we're to the point we've got 2 or 3 organizations that actually want to use it to make real decisions. They're not used to having this kind of information at their fingertips. Annie's also added other components now where she can talk about which population is served by which hospitals. Is the poverty level higher or lower than the Medicare rate? For example, the Bronx, as you may know, is very poor. About 60% are below the poverty level, and about 60% are in Medicaid. The Upper East Side is very affluent. About 6% of the people are below the poverty rate, and almost no one is on Medicaid. So there's an opportunity maybe to incentivize a provider to pick up those patients. You might think getting them on Medicaid is just more costs. The problem is if you don't get them on Medicaid, then their health problems get worse, and you have to pay for them later anyways. So let's talk a little bit about what we've learned in this journey and entertain your questions. So as we talked about the healthcare system and way back with the Institute of Medicine, the basic problems were medical errors and feeling that the quality of service was not as good as it should be. For example, one of the IOM studies showed that from the time a new practice is proven to be the best practice till the time that the majority of providers use it is 17 years. And the way people provide care tends to be the way they were taught in medical school. So how do we improve those things? At the same time, we have the runaway healthcare costs. And so the question was, how can we both improve care and how can we get a hold of costs? This series of case studies we went through with different providers, different organizations, was mainly not to predict to them, this is the right answer, do this. It was to help them to get insights into their problems and what was causing it, what was the outcome sensitive to. And that insight has been very important because some of these things is very hard to predict. I mean, so the healthcare enterprise with Emory, we predict 7% ROI. In this case, the CFO didn't ask it, but I've had this asked. What's the chance that we'll get exactly 7% ROI? I said, well, it's a probability distribution, so the probability is 0. Well, how can it be 0? Well, the probability distribution of the probability of any one point is 0. Okay? But the key point here is that you need to stratify your population and manage it by risk, not do this one size fits all. That's the lesson. Not whether it's 7% or 8% or 5%, whatever. And so we're getting more and more people coming to the Emergent Lab, seeing these demos. We have another one. We simulate the care for Alzheimer's patients. And in Indianapolis, they actually go to people's homes. So the Alzheimer's patient is about 2,000 they're dealing with. The care coordinators go to their house every month, a month or week, depending on their condition, and actually check in with them. And this is dramatic improvement in healthcare, lower emergency room costs, lower inpatient admissions, better outcomes. Interestingly, the healthcare costs with Alzheimer's, there's not much you can do to stop the disease, but you can improve their quality of life. But the interesting thing, the biggest savings in healthcare costs, other than the emergency department visit and inpatient admissions, was the health of the caregiver. The health of the caregiver dramatically improved by having a care coordinator stop by. Okay, the caregiver is usually a relative. The care coordinator stops by, and they're empowered if they see that the caregiver is kind of stressed out because mom or dad has been a little crazy lately. They'll say, look, why don't you just take the day off and go do some things you got to do, and I'll just stay. And the idea of having this stress relief has had a tremendous impact. Even when they don't use it, they know it's available when they need it. And there are enormous instances of this. The book I did with Dennis Cortese, this book I did with Dennis Cortese, who's the CEO of Mayo Clinic. We have wonderful case studies in this book. In Chapter 2, Christine Castle, who now is the CEO of the Quality Forum, writes this chapter about care in San Francisco. And they were doing, in this neighborhood that had a lot of elderly couples, elderly individuals, they decided an experiment. They would have a nurse visit each house once a month for an hour and talk about how they were feeling, talk about whether they're taking their prescriptions, talk about if they have any issues or any worries. If in fact it was something that was you need to go to see your physician for, okay, if it's something you shouldn't have to worry about, et cetera, et cetera. That once a month, 1 hour, reduced hospitalization in that population by 85%. Because they had someone to ask questions from, they had someone to interact with. There's numerous studies like that. And one of the things that I think is really interesting, our work with Piedmont Hospital, we did a lot of projects with them, with undergraduates doing these projects. One of the senior doctors said, you don't really need to give us ideas about how to do medicine. We know that, and we have lots of ideas. What we do not understand is the economic implications of adopting any of these ideas. We have no idea how things ripple through the system. And that's a place where I think engineering can provide a tremendous amount of value. And this lecture, with the exception of the New York simulation, is all of these are in this book that came out last year. And with that, I'd be glad to answer any questions you might have about this kind of work.
Thank you very much.
One thing I want to mention. So we're doing this with healthcare, we're doing it with cities. We're also doing it with vehicle systems. Not modeling the vehicle so much as modeling the industry and looking at how change happens in the industry. Enterprise diagnostics, I mentioned. People say, how can you work in such three diverse areas? And the answer is the underpinnings are the same for all of them. The same set of models, methods, tools, obviously different parameters, different structures. But so it's not as diverse as it sounds. Yeah.
How do you calibrate this model? For example, the Emory thing, right? So do you use the old data to?
We try. Our first test is, can we, with our structure and parameter estimates, can we predict how they're doing right now?
Okay.
That's the only real data we have, because all of this is
almost
what
like
if.
system identification.
This is all what if, right? And so we do try to calibrate it that way. And sometimes we have an occasional lucky data point, like for example, Annie had these other hospitals that had merged outside of her time window. And the question is, did she predict that would happen? And she had. It's very difficult. The question, and of course doctors ask this a lot, is what's the predictive validity of these methods? We said, in many cases we have no way to fully validate what we're doing because we're doing what if. I said, the really important thing is whether you get new insights from this that you walk away with, have new ideas about how to run your enterprise that are prediction-based, but the insight is important. Then you might, for example, do a small empirical test of that insight and see whether you really do get that kind of result. The Institute of Medicine has had this program for a long time called Evidence-Based Medicine, the Roundtable of Evidence-Based Medicine. And they did a workshop on engineering the learning healthcare system, and I chaired that. And what we've argued for here is not just evidence-based medicine, but evidence-based policy. And that is totally new to them. The way they do policy is they sit around the table. They may have a little bit of data, but it's all data about what is, not what if. So they're not projecting forward. If they project forward, they assume everything will continue to run just as it is running now. Other questions? Yeah.
You mentioned about pharmaceuticals and ads, some of those ridiculous things. What is the role in the cost of providing medicine?
Pharmaceuticals is significant.
That's why I'm asking. I know, and they have
for
a
example,
weird cost structure.
For Alzheimer's, that's the only thing they can do for you is drugs, and there's no evidence that any of them work. But people feel better because they're taking it. I mean, psychologically, they're doing something. Diabetes is very heavy on drugs, too. I mean, the only thing the healthcare system can do for you is give you a drug or cut you open. Right?
What about the cost that they charge for various drugs? I mean, they got, like 10 to 1. They're willing to sell in Canada for less, in Asia, South America, and, in the US, you got to cover all the developed
That's
R&D.
right. In fact, the big one that people are worried about is the drugs for hepatitis C. Because the number of people that have hepatitis C is huge, and it's I don't know, thousands of dollars per person. And if they actually allowed it, it would be billions and billions of dollars for this one drug. That isn't controlled now. But there are some drugs for people who have rare diseases where, like, for example, 1 year of drugs is $500,000. But then do you deny it? And so some of them are being covered by payers, some of them not.
Are those costs realistic compared to the development and production?
Well, in some cases, so for example, they develop a drug that benefits people, and if the whole population bought it, it would be like 1,000 people. I think that's very expensive to just serve 1,000 people. I'm sure the profit margins are enormous.
That's why.
Yeah. But there hasn't been any attempt to try to control those margins yet.
The lobbying is very effective.
Yes. Yeah. No, we haven't looked that much at drugs. We looked at drugs, like the drugs that, when we simulated the Emory thing, we had all the drugs that diabetics and heart disease people take. And it's just an enormous number. I mean, I don't mean number of pills, I mean the variety of prescriptions is really astounding. I mean, I've known people, I know some now, who every morning get up and take 20 different prescriptions. And it's all the different specialists. And they say they understand whether these interact or not. I'm not sure I fully believe that. Because how could you have run all those experiments, right?
Yeah, I think this whole issue of outcome-based thing, I think, is a good idea.
Mm-hmm. Yeah. And the reason we've got into this with several of them is the leaders of these providers said, if we go to outcome-based payment, we don't know how we're going to survive in that. We said, why don't we explore alternative organizational models to see what they would imply?
So what would be the major change there? Like the kind of thing that you're saying, like doctors will be paid some constant amount from patients per year.
Right.
It's like insurance, basically.
Yeah. But the question then, who gets what piece of that pie? Right now, it operates so that you're the endocrinologist, you're the cardiologist, and whatever you do, you send a bill in for that, and you get paid for that. Now you're just asking for a sliver of the pie from someone who controls it, not from the Medicare. It changes the dynamics, really rather remarkably. Imagine if our defense companies that we're familiar with didn't get paid for their airplanes or whatever, their aircraft engines. They just got paid when they were used. Rolls-Royce does some of that.
Right, yeah.
So is the resistance from the specialists or I would think the primary care doctors would be.
Primary care doctors are probably going to win out in this.
So
there is resistance from the specialists. Although it's interesting, the specialists seem so focused that they aren't necessarily paying attention to the broader issues of what's going on around them.
I think those specialists, they just like to do more surgeries for whether you need them or not. So I've had that kind of situation. They wanted to do surgery on my knee. I said I started exercising, went away.
Well, I mentioned I had this problem on my back,
yeah.
And I moved. I tried to change to a new neurosurgeon. I haven't had any surgery at all. And my surgeon recommended it. And I called the guy up, and he said, his assistant said, well, when can we schedule you for surgery? And I said, well, I don't want to be scheduled for surgery. I just want to have a relationship with a neurosurgeon, so if I need that eventually. She says, if you aren't willing to have surgery right away, we're not willing to talk to you. That's what they do, right? These public-private systems are interesting because they have so many stakeholders. And the cities are a good example. Like if you want to get a major change in New York City, one of our faculty members is the former chief urban designer in New York, Alex Washburn. And he has this table of what change you might like to get, a zoning change or whatever. Okay? And then he has who has what say in this process. It's really astounding of what it takes to get changes to happen. And as you can see, as I presented early in this talk, there are a tremendous number of stakeholders in healthcare. A tremendous number of people whose livelihood are premised on the system continuing to operate the way it operates now. I think it's true in higher education, too. Healthcare used to be the poster child for runaway costs, but things have gotten better in recent years. The poster child for runaway costs is now higher education. And we've been spending a lot of time on this. The National Academy of Engineering is spending a lot of time on it to try to understand the dynamics of the system and how this results. Administrative costs in the last 10 years have grown per student 63%. The cost per faculty member per student has gone down by 4%.
He's happy to hear that.
We are faculty, and we have our problems with the administration and how they inflate their numbers.
Well, the problem also is mission creep. You keep on adding more and more services that are that go beyond the original mission.
Yeah. As I say, politically correct services.
Yeah. But then, with sports, I mean, the three highest paid people are you got your three coaches.
Of course,
right?
of course.
So why are these insurance guys, or maybe why are these so-called right the political spectrum so against all this Affordable Care Act?
Well, they're afraid, I think, that it's more government control. I think they would certainly argue for decreasing costs, maybe just by decreasing services. I mean, the minimum cost healthcare system is obvious, right? We just get rid of healthcare, and so that trade-off between care and cost is a very interesting variable. Once you start to include, so you might find this interesting. When I chaired the National Academy's Healthy America Initiative, one of the things, there are a lot of very bright people from around the country. One question was, well, what's our real goal here? Is it just to lower healthcare costs? And we talked about it quite a bit. And we finally decided we couldn't just focus on improving healthcare, because you can't improve healthcare without improving education. And so we finally came up with an overall goal that our goal was a healthy, educated, and productive population that is competitive in the global marketplace. And we thought if we could just accomplish that, everything else is fine. And so we focused on some of those issues of how to, for example, people do things that are really detrimental to their health they don't understand. How do we get people educated so they understand? The Institute of Medicine found that if you have 100 points that affect your health, 40% are due to lifestyle, 30% are due to genetics, 20% is due to the environment, and 10% is due to the healthcare you get. And so your lifestyle is enormous impact. So the education part is very important. One of the things, I've looked at that broad goal in different ways to achieve high unemployment, high health, everybody graduate from high school, et cetera. I've looked at different ways of doing this. And so I was in Washington. I go to Washington about a week a month. And I was talking with a person who had just left the Obama administration a few days before that and went to become senior vice president of the Red Cross. And he had been head of disaster preparedness at the White House. He was the person in charge of the Ebola reaction. I asked him, there were so many ideas that seemed so obvious. Why do we have an inability to make a decision? And I said, because is it ideological that people actually on one side or the other just think this is the wrong thing to do? And he says, no, actually, many of these things, everybody agrees it's the right thing to do, but they just don't want you to get credit for it. They would rather nothing happen than you get credit for it. He said, that is the predominant problem.
So then we are in the ideal political spectrum divide.
That's the deadlock.
Yeah.
Oh, you too?
Your explanation. Oh, we have a running discussion.
He had to give me a free
I had
dinner
invited
in
for dinner
Cancun.
after the election of Obama. I have another question.
Was that a celebration dinner or that was a payment?
It was his celebration.
Okay.
And my pay. Anyway, you mentioned that vertical integration from service provider to insurance.
Mm-hmm.
Is this a contemplated thing? I mean, I think Kaiser is doing it, or has been doing it for a long time.
Mayo has their own insurance
Yes.
program. Geisinger has.
Yes.
Yeah, yes.
So that's the way that you see that things can become more efficient.
Yeah, what if it's all decentralized? Every hospital starts
So,
insuring
I
people.
mean, 20 years ago, there were HMOs and they sort of died off. I mean, what's changed in those 20 years that it makes sense now?
That's a good question. I mean, I think there is some similarities. Of course, the thing you have to add to all this is you have to have a quality standard for care. Otherwise, the provider will just try to save money so the insurance company can make money. Right? So the quality standard. Maybe, well, I guess one of the things is the potential auditability of it now. But you're right, there is some parallels, and that didn't work.
Any other questions from students?
So you can see that your engineering skills are applicable maybe more broadly than you realized.
Right. I think the last row guys will probably appreciate it because they're doing something involving some humans. The rest of the guys are pushing equations.
In our research group, because we're working on things like healthcare in cities, our PhD students are predominantly women. I think 65, 70% of our PhD students are women. I think it's because of the topics we're working on. They're engineers, but they're women.
I think I had probably the largest number of women PhDs that graduated under me.
Yeah.
That's
Just
because,
like
because he's so liberal.
Women tend to go more to bioengineering rather than what we call hard engineering. How do you call bioengineering? Krishna?
I don't know.
Well, I know. You want me to say how you call the liberal arts of engineering?
We did a proposal with Sloan Kettering, and their cancer biology folks did a big proposal, which didn't get funded, but it actually got very good reviews, on taking these multi-level models and applying it to cancer biology for signaling within the body. And I learned a tremendous amount of things from this. We're still continuing to pursue it a little bit. For example, you get cancer all the time, but your body shuts it down. The signaling system activates the right cells and they kill it. But occasionally the signaling system has an aberration, doesn't work, and then the cancer's growth reaches a certain critical mass, and then the system can no longer shut it down. And so the whole understanding the signaling among the 50 trillion cells in your body, how this all coordinates, I mean, it's an amazingly complex system. But we can actually approach it with some of the similar modeling paradigms we've been approaching these other problems with.
Yeah, well, we have major efforts. I think that's something that we can talk to the dean, make sure that he knows about it.
Mm-hmm. Okay.
What is the center that we have? Genomics?
Yeah.
Yeah, we came up with, in this class I taught, in the book that's coming out shortly, 6 problems that we take every idea and every technique and bounce it off of 6 problems. Healthcare delivery, cancer biology, urban systems, traffic congestion, counterfeit parts and supply chains, and the financial system. So we have these 6 archetypal problems. So whenever everybody comes up with a new idea for modeling, you say, okay, how does it work against these 6 problems? The requirement is not that it work for all 6, but that we test it against those 6 problems.
I think they're involved with the counterfeit thing, right? We got a center called Chase, Center for Hardware Assurance and Security. John is also leading that center too, I forgot. So he's involved in at least, he's got 3 hats.
This is a project through the service to the Indonesia Center on counterfeit parts, because this is a big concern for DoD.
Yeah, they got some major stuff.
We can talk about it.
Okay.
So I think you could probably have a lot more than just what we are trying to do with the ETC. There's a lot of other activities where this kind of technology would be quite useful.
Well, thank you.
Thanks a lot.